A very good morning, everyone. Uh, Professor M. Tanveer, sir, and welcome to the 18th day of the Deep Learning Summer School by IIT Jabalpur. I am Sunana Singh, and it's my pleasure to chair this session. I hope you all are enjoying these sessions so far. It's a privilege to introduce Professor M. Tanveer from IIT Indore, a distinguished researcher and academician in the field of artificial intelligence and optimization. He currently heads the Optimal Research Lab and is a SERB Ramanujan Fellow. Professor Tanveer holds a PhD in computer science from Jawaharlal Nehru University and an MPhil in mathematics from Aligarh Muslim University. With over 18 years of experience, he has published more than 170 research papers, which have garnered I'm sorry, I might be disconnected. I'm audible. Am I audible? Okay. He has published more than 170 research papers, which have garnered over 9,100 citations. His work spans across support vector machines, optimization, deep learning, and applications in healthcare, such as Alzheimer's and dementia diagnosis. He has been recognized with numerous national and international awards, including the INSA Distinguished Lecturer Award and the IEEE CIS Distinguished Lecturer title. Sir, we are truly honored to have you with us today. I would now like you to kindly take over the session and please continue.
Yeah, thanks so much, madam, for the kind introduction and the whole organizing team for inviting me to deliver this talk in the online mode. So let me share my screen and please see if it is visible. Oh my God. So there could be some issue. I hope you are able to see my screen.
Yes, sir, it is visible.
Uh, is it visible now?
Yes, sir, it is visible.
Okay. So, yes. Yeah, good morning, everyone. So, today I plan to speak on this topic, advancing Alzheimer diagnosis, the role of shallow and deep learning algorithms. So, I'll start with the very basics about Alzheimer's, and then later on, I plan to discuss what we have contributed from the last few years in this direction. So I'll speak the advantage of shallow and then move to deep learning algorithms. So now let me first start with the definition. What is Alzheimer disease? Uh, so you can see that Alzheimer disease is one of the neurological disorder disease, and it was named after one doctor from German called Alois Alzheimer, who was the first to diagnose in 1906. And if we say the dementia cases, so around 60 to 80% are there. And we see that usually neurons die, a breakdown in the cell communications. And we see that the brain is shrink due to this AD. And what we also see in the literature that most commonly we see that this disease is when the age of a person is more than 65 or maybe older. So, and due to this cell damage and also death in critical brain areas, so that can also impact memory and cognitive functions. So according to the report in 2018, so around 50 million people were affected by this disease, and it is expected to be 3 times in 2050. So the early detection, early diagnosis is very, very important. So what to do? So we need to develop some automated models for the early detections, predictions of this deadly disease. So we can see that a few symptoms of Alzheimer's disease, like we see that challenges in planning or solving problems, confusing day from night, inappropriate use of words, mood changes, memory loss, and gradual loss of ability to perform normal tasks, loss of vision and coordination, and inability to recognize and use familiar objects. So if one feels that there are more than 50% symptoms from here, so I think it's better to be alert and consult. Uh, so let's go further deeper to see the inside the human brain. So you can see that there are few other terminology here and few more information. So in general, what we see that in the human brain, so the weight is around 3 pounds, and the size is just we say a medium cauliflower size. And there are many, many neurons in a human brain. So we just say that more than 100 billions neurons. And synapses is also more than 100 trillions. So if you look at more terminology like cerebral hemisphere, so these is the place where sensory information received from outside world. So this part of the brain control voluntary movement and regulate conscious thought and mental activity. So, and this part is essentially 85% of the brain weight, and it consists of two hemisphere connected by the corpus callosum. And if we look at cerebellum, so usually this receive information from the eyes, ears, and muscles and joint about the body movement and position. So, and there are several other means terminology that you see that hippocampus, thalamus, hypothalamus, and limbic system. So if you look at this brain stem, so just you see the uh, downside in this picture. So that is essentially connected to the spinal cord. So, and this control automated functions such as heart rate, blood pressure, and breathing. So the brain has, as mentioned, that billions of neurons or nerve cells that carry messages between different parts of the brain. And Alzheimer's disease causes damage to nerve cells, which stops them from working properly. So due to that, our the brain of the AD person is shrinkage. So our brain control everything what we do. So if messages are not received, it means that there are some difficulties. So we see here that how the brain normally work. So we can see that we can start from the top left, like this part is the frontal lobe. So that control thinking, planning, solving problems, and behavior. And in the top right hand side, this is called parietal lobe that control awareness of our surrounding and coordination. And this is occipital lobe, just below parietal lobe. It helps us to interpret what we see. So, and this is cerebellum. So we already have seen this part that control balance and movement. And this is in the green part. So this essentially is a language and speech, and just convert those. And temporal lobe that control memory, learning, and understanding. So it is very clear image here with healthy brain and Alzheimer disease patient brain. So we see that the left side of this picture A, so it shows the healthy brain, and the right side, half part of it, is showing the Alzheimer disease patient brain. And it is clearly visible that this brain is shrinkage. So we see that how it impact everything in the brain. So, and we can see on another figure, right hand side B. So we see that the healthy cells and Alzheimer's cells. So we can see that this part essentially affected by these Alzheimer's. So now let's move forward and see the diagnosis of Alzheimer's disease. There are few steps. So like first is neuropsychological assessment like CDR, EDAS, and several other like MMSE. So, and if we look at neuroimaging modalities, so we have like MRI and PET, they are popular techniques. And we also go the blood test and go for the genetic data study. And AD is only diagnosed with complete certainty after death using autopsy. This is also another important part. Yes, I mean, if we go with the complete certainty, so that is usually come out after the death of the patients. So as we mentioned that the popular neuroimaging modalities are MRI and PET. So neuroimaging has provided one of the best modern tools for examining the pathophysiology of mental illness in the brain. So, and MRI is one of the most significant milestones achieved in medical imaging. And Alzheimer's disease leads to structural changes in the cerebral cortex region of the brain. And MRI can visualize changes in characteristic locations that can yield diagnostic accuracy. And MRI can also represent the structural changes from control normal to Alzheimer patients, along with like we have MCI, and now we have one more stage called early MCI, mild cognitive impairment. And MRI is one of the known invasive modalities compared to other imaging modalities. PET, another neuroimaging modality. So, but we usually say that this is invasive modality that we have to inject that occur in the brain due to protein accumulations. So this is just a 3D, I mean, it's just a view of MRI images. This we have shown that this is called sagittal plane, and this is control plane, and this is transverse plane of an MRI. And this is, we can see different images of Alzheimer and control normal, that is called healthy, and MCI. MCI is a case mild cognitive impairment just before the Alzheimer. So middle stage, we usually say. So we easy to visualize that if we compare with Alzheimer and control normal, healthy. So it's easier to visualize from the images. But it is difficult with MCI with AD because the images are very, very close. So it's really challenging to detect or I mean is classify these two different kind of images. And we have now more like early MCI. So early MCI and MCI, the classification is really difficult because they're very, very close. So these are another more information about MRI. So we see that different kind of visualization. So like we have sagittal plane slice that we have taken from online repository ADNI. So we see that relevant brain regions for Alzheimer's disease diagnosis. So, and we see here, this is sagittal plane, and now we have like healthy image middle slice and Alzheimer's disease middle slice. And we see that we have white matter, we have this is gray matter, especially for the AD part, and we have the CBS, CSF images. So what we see here that usually we see the reduction in the brain gray matter volume. Here we can see in case of AD an increase in CSF volume, thereby reduction in white matter volume and reduction in gray area and increase in stress. Now, let's forward and see the importance of early diagnosis of Alzheimer's disease. As I mentioned that we usually came to know about this disease at the age of 65 or older. So, and at the time, AD is an advanced stage and very difficult to diagnose. And there is no option to revert back this disease. So at that stage, usually means at that advanced stage, no option, but the patient die. So, and since Alzheimer's disease, this disease is incurable, and the only option is the early diagnosis. So the early diagnosis is the only option, and that can help the patients. It is very tough to predict Alzheimer's disease at the early stage, as there is no defined set of symptoms of the disease. For example, if you say that memory loss, okay, so there could be several other issues where the memory loss. So, I mean, is we cannot say that if the memory loss, then this is only the symptoms of the Alzheimer's disease. So, I mean, that's really tough to predict AD at the earliest stage. And the severity of Alzheimer's disease, as I mentioned, that it leads to the death. So the only option that if we could find out a way and develop some algorithm that can detect this disease at the early stage. So early diagnosis is the prime objective. And brain aging is yet another challenge to differentiate. So neuroimaging techniques are crucial in the timely detection, diagnostic assessment, and therapeutic intervention. And neuroimage analysis traditionally involve human experts such as radiologists and clinical people. However, due to large volume of neuroimages, it poses challenges, and the process is time consuming and vulnerable to human biases. Therefore, doctors and researchers uh, so they're coming forward and use ensemble deep learning techniques to automatically discover important features and interpret the neuroimages to improve the efficiency. So in the last a few years, deep learning has rapidly become a preferred tool for neuroimage analysis to detect Alzheimer's disease in a timely manner. So, how our research impacts society? Like the first is that early detection or the detection at least and intervention. So our research facilitate detection of Alzheimer's disease, which is crucial for timely intervention, and the development of accurate Alzheimer's disease detection model contribute to making diagnostic tools more widely accessible. that facilitate timely medical attention and support for affected individual. And by developing or by using deep learning algorithm, we contribute to deeper understanding of Alzheimer, advancing both clinical applications and broader neurogenerative research. So let me start with the shallow learning algorithm where Alzheimer has been used. So then I'll come back for the recent contribution to the deep learning. I'm sure that at least SVM is known for many of you. So support vector machine is one of the most powerful tool of machine learning, initially used for classification problems, uh, and then regression, then clustering, then semi-supervised. So uh, it was developed by Wapnick and co-workers in 1995. So, and since then it has been used widely in most of the directions. I mean, if you look at people with background computer science, electrical engineering, or any branch of engineering, and even healthcare, even sciences like physics, chemistry, maths, so, or in the healthcare domain, so all are at least using SVM or advanced SVM algorithm for classification for the predictions. So the basic idea of support vector machine is to find the best line or best hyperplane between positive and negative classes. So if you look at the objective, as I mentioned, that we need to find out the best hyperplane, like here W transpose X plus P equal to 0, between bounding planes, like corresponding to class +1 and class -1. And the data points which lie on these supporting planes is called support vectors. So why we say this support vectors? Because they are the only points that help us to decide the middle line that is called optimal hyperplane. So we need to, I mean, if you look at the concept of support vector machine here, uh, initially with this geometrically, and then you will see that how it has been interpreted mathematically. So I mean is, suppose we have one class of sample this side and another class of samples this side, and we want to classify this kind of data. I mean, is we have one class data points, we have another class of data points here, and we want to classify this kind of data. So we want to classify this data in such a manner that the distance between these two class data points is maximized. So we see that, I mean, this is a very simple example of the hard margin. I mean, is there is no misclassification. So I mean is if you look at in the classroom, in one side boys are sitting and another side girls are sitting, right? And we want to classify that data using support vector machine. So the idea is that we need to draw a line in such a manner that the distance between boys and girls is maximized. So if we have the best separation, so this is called optimal hyperplane, right? So I mean is without compromising any misclassification, right? So I mean is we need to I means we need to classify in such a manner that the data points of this class is above this one and below this side. Okay, and the distance between these two lines is maximized. So we simply, with a simple mathematical formula, that if we want to just take the difference between this and this, so this is coming out to be 1 upon norm of W, and this is 1 upon norm of W. So total is 2 upon norm of W. So essentially, we need to maximize this I mean is this will be maximum 2 upon norm of W subject to the constraint W dot X plus B greater than or equal to 1. I mean data point which lie here and above this. Okay, and at the same time, here W dot X plus B less than or equal to -1. It means that data point which lie on this line and below this. So this is called the standard support vector machine, was developed in 1995. Now, suppose if there are misclassification, I mean, few data points of this class lie on another side, or some data points from this moving for another side. I mean, they are wrongly sitting in their places, right? So it means that we go exactly in the same manner, but if any data point is wrongly classified, so we need to penalize those data points with some xi or slack variable. So I mean is we just add those, and here C is a parameter that control the overfitting. I mean is you can see that this is what I was discussing. This is exactly is written here in mathematics form. So I was mentioning that we had to maximize 2 upon norm of W. So essentially, equivalently, we can write minimize W, minimize norm of W by 2, or we can say minimize norm of W square by 2. The same thing is written here, minimize half norm of W square. So, and since if there is a misclassification, so we just add this one. If there is no misclassification, hard margin, so we just put this is 0, this second part. Okay. So, and xi here, xi I is also nothing, 0. So, I mean is, this is called soft margin SVM algorithm. So, if we move forward and we want to solve this problem, I mean is we have a quadratic programming problem. We have objective function and subject to constraint of both the classes, corresponding to class 1 and -1, or class 1 or class 2, whatever you represent. So the idea here is, first we need to construct a Lagrangian function, okay, and then we take the partial order derivative with respect to here W, B, xi, alpha, beta, and we got this dual problem. Okay. And we see here that this is our dual problem and we can easily solve it. And here, this part is essentially input data points. And what we observe that here, those data points appear in the form of inner product. This point is very important and will help us to understand when we are going to discuss highly complex case. So you see that we already have seen the linear case in the last example. Now, if we see here that if we have this kind of data points, I mean, we have red data points on one side and left blue data points on the right side. So it's very simple that we draw a line in the middle and we say that this is linearly classified. So what can you say about the second example? So can we classify this data linearly? No. I mean, is this will be kind of, if you want to classify, it will be in the curve form. So, but we cannot classify linearly, right? So, but what we see that if we move, I mean, is we cannot classify this in the linear case, but if we move from lower dimension to higher dimension, I mean, is the same data points, if we move from real line to plane in such a manner, like a function fx equal to x square. So, and you impose on each data points. So what we see that data points will move up, and we observe that we draw a line and we can classify this data. So this is just into motivation that the same data points which were not classified linearly in lower dimension, the same data can be classified linearly in the higher dimension. So with this motivation, we are discussing the highly complex problem. I mean, as you see the first this example in the left side. So this is highly complex data, and we want to classify this. So we see that we cannot draw a line between red and blue data points. But we can map this data point into some higher dimensional space such that you see the right hand side, the data is linearly separable. So let us assume that we have a map phi from Rn to Rm. I mean lower dimension to higher dimension. Rn means Rn to Rm. Here m is greater than n. So we see that as long as we calculate the inner product in a feature space, so we do not need the mapping explicitly. We see the importance of this function phi. So in later stages. So and there are several I mean, as if we see here, this is a function phi, and let me try to explain a bit. So kernel functions. So it is represented as k xi comma xj is phi transpose phi. So here phi is a nonlinear function that map in input space into some higher dimensional space. So we see that if we take an example like here phi, and we take inner product, and we see that that can be represented, and we even define this kernel functions, and no need to carry out phi explicitly. So it means that the use of kernel functions to carry out phi explicitly is known as kernel trick. So let's move forward, especially for the nonlinear case of the SVM. So here means we have this formulation exactly in the same manner what we have seen in the linear case, except this term phi. In place of xi, we are just writing phi of xi, and we are solving exactly in the same manner that we construct the Lagrangian functions, take the partial order derivative, and we got the dual. So what we see that this is also the similar representation, except this one phi transpose phi. And we already discussed that phi transpose phi can be written as k. And k is a kernel function, and there are many kernel functions available in the literature that can be used. So I mean is that we are working on a high dimensional, I mean highly nonlinear or highly complex data, but work linearly with the help of phi or with the help of kernel. So this is another beauty of support vector machine. So now there are number of variants have been developed in this direction. Like Twin SPM was developed in 2007. So, and this was developed essentially with the intention that to improve the efficiency, as using support vector machine is computationally heavy. I mean, is we need to solve two large quadratic means a large quadratic programming problem. So instead of solving large QPP, so using the concept of twin SVM, where we are using two non-parallel hyperplane rather than a single hyperplane in such a manner. So we are solving essentially two smaller kind of quadratic programming problem. So with this, if we look at the training time complexity is approximately 4 times faster than usual SVM. So, I mean, as you see that we just write the formulation of twin SVM rather than solving a large QPP. I mean, we have one objective function corresponding to the constraint of both the classes. So instead here, we have an objective function like A is corresponding to class +1 and B is corresponding to class -1. So I mean is we are just we are just mentioning in this manner the data point of class 1 is close to its class and at the same time is far from the another class, right? So the same thing is written that some of those data points of class +1 subject to the constraint that this is far from the class -1, that is B. And this second part is essentially that we are sum up those misclassification, and here C1 and C2, they are the penalty parameter that control the overfitting issues. Now, similarly for this part, equation 2. So for more information, you can find out this paper, PAMI 2007. So dual formulation, we are just writing in the same manner, and we just write, means we construct the Lagrange functions, find out this dual, and we see that we just find out the solution like WB corresponding to class plus 1 and minus 1. So what we observe here in equation 3 and 4, so here matrices appear in the dual formulation may not always invertible. They are so this is square matrix, but all square matrix are not invertible. So to do that, we just include an extra regularization term. Delta is a very small positive number, so to make it invertible. So, but this is manually being added. So there are number of algorithm after that have been developed. I think after 4 years, in 2011, and later on, by introducing extra regularization term in the objective functions to make it automatically invertible. So a lot of improvement have been done later on. So I thought to discuss this also. This is another efficient algorithm. This is extremely fast. As very small change in this algorithm, I mean is just replace one norm with the two norm of this slack variable in both 5 and 6, and just replace inequality with the equality of the constraints. And since due to this two norm, this xi and tau is redundant with the strict conditions of non-negativity. Okay. So now there are a lot of work done, especially for support vector machines, twin support vector machines, and advancement, especially for Alzheimer's disease. So I'll try to discuss a few algorithm for the deep. So this is another recent variant in intrinsic fuzzy least square queen SPM for Alzheimer's disease. So like we utilize intrinsic fuzzy score function to reduce the effect of noise or outliers and address class imbalance problem with adaptive sample weighting. And we also incorporate a regularization term that is grounded in statistical learning theory. And we propose two models here, and this is just to improve the efficiency. And we apply essentially for the Alzheimer and breast cancer. So these are just a summary. I think more information is please see here. So there are several baseline algorithm, and the last our two proposed one, and we see that the most difficult case is the last one, that is MCI versus AD. So, but what we observe that our proposed algorithm is performing very well in most of the cases. So you can see that especially for IFLSTSVM. So for this one, we are getting the 71% accuracy. Okay, so this is very really recent contributions, and what we have done that we developed one loss functions called wave loss. So this has been developed recently, and this work has been published in pattern recognition. So what we have done, so we propose this called wave loss functions. So the importance of these loss functions are that this loss function is robust to outliers, noise insensitive, and smooth. So, and we integrate this wave loss into least square support vector machine formulation and developed a robust and smooth classifier called wave SVM. And we employ Adam optimizer. So because this is more scalable and efficient for large biomedical data sets. And we have validated on ADNI. This is most preferred data set in Alzheimer's disease. just to see the diagnostics task in Alzheimer's. So let me explain a bit theoretically this loss function. So this is the mathematical formulation in equation 7. So here A is a shape parameter and lambda is a bounding parameter. We see that when we change different u and we fixed the value of lambda. So, and you see that we are fixing a equal to 0.5 and here a equal to 1 and a equal to 1.5. So, and we see that we are getting different kind of representation. So we just fix lambda equal to 1 and different values. So now for any, if we look at theoretical properties, this what we say that this loss function called wave loss function is classification calibrated. I mean is that the function which minimize the expected risk overall measurable functions corresponding to wave loss, it has the same sign as bias classifier. So we see that what does it mean? So I mean as when the value of the p is greater than 0.5, right? When the value of the p is exceed more than 1.5, so the minimum value is achieved for a positive value of fx here. And conversely, we see that when the value of the p is less than 0.5, so the minimum value essentially achieved when the negative value of the function fx. So essentially, I mean, is this behave as a bias classifier. So these are a few results. I mean, there are a number of results with UCI and other data sets. So since our focus today is on Alzheimer, so we are just including results for AD. So we see here that we have uh, 4 baseline algorithm. The last one is the proposed one. And we see that the difficult classifier is MCI versus AD. And we see that this is really performing nicely, that this is 79.45%. And if you see the baseline, the best baseline is PIN-SVM. This is 75.34. I mean, around 4% difference. This is significant difference. And we also have shown time also, and we see that wave SVM is also extremely fast. So now, if you are really interested in looking at the recent contributions, please look at these several variants of twin SVM in this paper called Comprehensive Review on Twin Support Vector Machines. So please look at it. You can see that a number of variants have been developed in the last 15 years, I think more than 15 years. So now, and you can see that these models, twin SVM based model, has been applied in several directions, especially more focus on Alzheimer and EEG signal classification. So if you're interested, please look at it. Okay, now I'm moving forward to discuss some work related to ensemble deep learning or deep learning for Alzheimer's disease. This is our recent contribution. If you are interested, please look at this paper. This is ensemble deep learning for Alzheimer's disease, characterization and estimation. It was published in Nature Mental Health. So our work has elaborated precisely on the confluence between Alzheimer's disease and ensemble deep learning. So that explain the fundamentals of this disease. So especially we see the contemporary diagnostic standard and biomarker like MRI, PET, and functional MRI. So we examine how these multiple modality have been modeled via ensemble deep learning that can improve the prediction of Alzheimer's disease. Our aim is to establish a referential guide to encourage research efforts in the rapidly growing field of ensemble deep learning for Alzheimer's disease. So, our aim is to foster interest in ensemble deep learning for detection Alzheimer's disease, so that can provide a benchmark for assessing present progress and offer new research avenues for future development. So we can see that this is just we have taken this picture directly from the paper. So we have like two different kind of like homogeneous and heterogeneous ensemble. For homogeneous, obviously we have the same base model will be the same, and for heterogeneous, the base model will be different, right? And like for base classifier will also be this different, and we are just using these for homogeneous ensemble, like we have bootstrapping, boosting, feature sampling, randomizations, and so on. So, and these are the future directions, especially for Alzheimer's disease. So, we see that mm, more model explainability is one of the hot areas. Is we have to give more insights about the features. Is if you are working in deep learning, especially in the healthcare domain, so you are giving input and using the deep learning model, so they are giving important features automatically. So, but this healthcare domain, especially clinical people, doctors, will not accept it. So they would like to know exactly the same each step process that how these features are extracted. So is we had to give a model which is more explainable to give more transparent diagnosis to the patients. So, and if we are developing some novel architectures, this is also another directions in this and region of interest, especially like in a brain. If a person is diagnosed with a full brain, so not a good idea. Is if a particular brain is affected, so then the relevant region should be used and extract the important features from there and do the further analysis rather than considering the full brain. And another is that we can integrate medical knowledge features with data-driven features. And we also multi-model data analysis, and we can develop some model that is uh, less, more efficient and less expensive. So, okay, this is another recent review paper, especially for Alzheimer's disease. And this is simple based on deep learning algorithm. So, in this work, we have given brief introduction and clinical finding of prevalent neuroimaging modality for Alzheimer's disease diagnosis. And we have discussed on available data sets, access for AD diagnosis, and we have given some introduction of deep learning for Alzheimer's disease, and we have given discussion on advantage and limitations of various DL algorithm for AD diagnosis, and the future scope we have been discussed. So if you are really interested to work in this direction, so please look at this paper. So this is also not very old, 2023 paper. So now we see that this is a workflow, especially in this. So what we have done that we have MRI scan and we pre-process MRI, and we have training data, test data, and validation data. So for example, we have an input and we have this feature learning, and from this we are getting this important features, and then we go for the classifier. Is whether it is AD or CN or MCI. Okay, so this is completely different direction and SMC, significant memory concern. So this is also very important as the memory is decline every day. So significant memory concern, also known as subjective cognitive decline. It refers to self-perceived decline in memory or cognitive abilities. It occurs without objective impairment on standardized cognitive assessments. SMC is typically reported by individuals recognized by close associates. So, what is the importance in Alzheimer's disease? So, SMC may represent the earliest symptomatic stages of Alzheimer's disease. So it is potential preclinical marker of future cognitive decline, including MCI and dementia. Early detection of SMC enable timely monitoring, intervention, and risk assessment. It support targeted recruitment for clinical trials that improve predictions of Alzheimer's disease. If you are interested to see, so we had done comprehensive evaluation and we have given our recommendations that which algorithm could be more suitable for SMC. So please look at it. This is recent work, and this is just a framework that we have used. We have the pre-processing stages, and then we have another like feature extraction, and we used different classification approach. I mean, if you are using hyperplane based approach or randomized neural network. So these are the top 5 features. So let me just move forward and discuss a few algorithm like intrinsic fuzzy RVFL. So I'm sure that you are also heard about RVFL. This is another classifier, randomized space classifier like ELM broad learning system. So here we have used intrinsic fuzzy concept in RVFL so that assign score values to reduce the impact of noise and outlier. So that enhance standard RVFL by incorporating membership and non-membership functions for sample-wise assessment. So, and we have validated on several benchmark database, and we have used several baseline algorithm and our main focus was AD diagnosis. So we have used ADNI database. So this is our idea that we have used this membership function and non-membership functions with these formula 10 and L12. So, and this is the score function that we have used, and more information is available here in this paper. And these are our results that with the baseline, several baselines. And we again observe that our results of proposed algorithm in the last column is competitive when we compare with RVFL. So, I mean, as other are also, yes, means less inaccuracy. So what we have done that this is another, this is based on broad learning system. So I mean is we use the same concept of intrinsic fuzzy in BLS. This is the first paper in BLS. So for using the concept of intrinsic fuzzy, so you can get this information from this paper, IEEE TFS. So we used a novel fuzzy BLS and intrinsic fuzzy BLS. So here, especially for the fuzzy, we used fuzzy membership functions that can assign adaptive weights to each sample based on proximity to each class centers. And for the intrinsic fuzzy, we incorporate membership and non-membership and score functions to account for homogeneity and heterogeneity in the kernel space for precise weight assessment. And then we apply on several baseline, several data sets. So here we are just focusing on healthcare domains. So we are showing only the healthcare data sets. So, but you can find out other other data sets in this paper. So, and we see that especially intrinsic fuzzy BLS outperforming on all the cases. So this algorithm could be really very useful if you are moving for Alzheimer's disease diagnosis. So this is another variant of ensemble deep RVFL. So here we have extended graph embedded approach in RVFL, and then we improve it. We had developed this deep variant and ensemble deep variant of this extended graph embedded RVFL, and we have applied AD data sets and see the performance. So more information is available in this paper, IEEE TCBB. So, and we see that we have considered several activation functions and several baselines. And we see that we have shown that the performance of the two models are shown in the bold faces. So it's easy to visualize, especially for the last four columns are the proposed one. Okay. Similarly here that we are just using for CN versus MCI, and this is MCI versus AD. This is a complex case as I was mentioning. So now this is especially for the class imbalance data. This is also the recent work was published in IEEE and NLS. So what we had done, so we used the concept of graph embedded intrinsic fuzzy RVFL, especially for the class imbalance data. So what we had done, we incorporate graph embedded techniques to preserve the inherent topological and geometric structure of the data. And we also utilize intrinsic fuzzy sets to manage uncertainty and imprecision, improving robustness against noise and outlier. And then we demonstrate superior performance on key database. Key database usually have imbalanced data and achieve, we see that we are getting achieve performance, especially for the AD. So you can see that since we are focusing on healthcare domain here, so here we focused on this AD data, and we see that the performance in the last three columns, last two columns. So, and we see the average accuracy is better. Okay, now we are using the concept of privilege information. So privilege information is the advanced information about the distribution of data. So I think I can just show the graphical representation that we have, we have input and we have the hidden layers, multiple hidden layers, and we have the privilege information, and then we give the output. So, and then we have the ensemble deep. So essentially we have uh, we have multiple hidden layers, and then we also here using the ensemble this privilege information concepts. So there are several results we have used. I think this is also published in the same journal, IEEE TCPB. So I think there are several limitations and advantages and possible directions we have given in this paper. So this is one of the review paper, especially for Alzheimer's disease. So you can see different directions, especially significant brain age estimations and brain age difference with cognitive decline. And one, I think I had not mentioned, but explainability is very important here. Okay, I think I'm moving in the last here. So just This is a review paper for the deep learning for brain age estimations. So this is really very interesting paper. So please look at it. So, and we got a lot of readers with this after this, and many people started working in this domain. So because initially very less number of people were working here, so we categorize brain edge estimation model based on deep learning, and we also classify deep learning architectures on slice-based, voxel-based approaches. And we examine modality, size of data, performance, and the data sets used. And then we enumerate several challenges and trace directions. So we have used this framework that we have this deep learning, and then our focus is brain age estimations, and then we see this. Especially to see the brain age of the person. And there are several possible directions, explainability here again is very important, and integration of multimodal data and brain age difference, and how to develop an algorithm which is more efficient, and develop a significant brain age algorithms. So, and finally, that if I say in concluding remark, that if we want to enhance healthcare domain through mutual supports, so data access and annotation is very important, and we should have our Indian-centric data set preparations, clinical insight and validation. We need help of the doctors, and domain knowledge exchange via some seminar on or hands-on session like we are doing today, demo practical on employing AI ML-based model, and model interpretability and explainability, and translation into clinical practices. So these are a few references, and I um, acknowledge this work to my students, postdocs, and whatever. So thank you so much. I'm happy to take any questions now. So
Uh, uh, good afternoon, Professor Tanveer.
yeah, please.
Yeah, thank you very much. Very interesting and useful, sir. I have a few questions because you went through lots of things and research.
Mhm.
So I think I'll have to, if I start with the first question, it was regarding the linear regression formulation for the twin SVM. Could
Mhm.
you please throw some light on that again? I think it was slide 34, 35 as a package.
Yeah.
Linear regression formulation of the twin SVM. Just could explain that once.
34, this one.
35, just like I think there was one slide. Was 35. Yeah, I think it's 35. Yeah, this one, I think.
Okay. So this is okay, let me see. Sorry, what happens? I don't know. What
Yeah, we
happened?
can see it.
You can see me.
Yeah, and the slide also.
And just wait, please. I don't know what's the problem. Uh, Shared again. Are you able to see?
Yes, sir, we are
Yeah.
able to see.
So I was discussing least square twin SVM, initially twin support vector machine algorithm. So I was mentioning, sorry. So essentially I was mentioning the only difference is and how this algorithm is efficient if we compare with our original twin SVM algorithm, and how this algorithm is going to be very useful in the literature. So the advantage is that this algorithm is least square in sense. I mean, is so we are simply solving system of linear equations rather than solving as a quadratic programming problem, as we have seen in support vector machine, as we have seen in twin support vector machines. So, and there is no need of using any optimization toolbox because we are simply solving system of linear equations. I mean, is if you want to solve it, let me first explain that. I mean, is if you compare with the Lisa's twin SVM, so what we had done, we just replace inequality with the equality. I mean, if you see in twin SVM, so we are just writing greater than or equal to this E2, or I mean, +1 or -1, and less than equal to this +1 or -1. That replace with inequality with the equality, and we are just taking here two norm of the slack variable. I mean, as you can write norm of xi square, you can write here a norm of tau square. So earlier in twin SVM, it was C1 E transpose xi. Here C2 E transpose eta. If you see in twin SVM, all right. So these are a very small change, but fundamental change that change the whole problem here. I mean, is if you see the people having background means non-background people, so since they want very simple algorithm and fast algorithm, so this is the one that we usually means researcher used it.
So,
So
excuse me, yeah, before proceeding, what about these constraints? Could you explain
yeah.
why they are written like this? What do they mean?
I mean, is if you see,
The negative sign in front of the first one, minus BW, and then there is no negative sign in front of AW.
yeah, A is correspond. Yeah, I think I have mentioned a few times that A is a matrix, and we are just writing that this is corresponding to class +1, and B is corresponding to class -1 data
Mm-hmm.
points. Okay, and W, B, and this is already clearly outlined corresponding to class +1 and -1, right?
Mm-hmm.
And like the first term in equation 5 in the objective function, so this is nothing but this is the sum of square distance of the data points corresponding to class +1. I mean, so I mean is we are minimizing those data points which is closer to its own class, right?
Mm-hmm.
And this is we are considering that this is uh, exactly at the one distance. This is equal to 1. Exactly at the one distance from the other class. So B is corresponding to data point of class -1.
Hmm.
And here, this second term as C1 xi transpose xi. Here, C1 is a parameter, as I was mentioning, and xi is a slack variable. I mean, this is the number of misclassification samples,
Hmm.
right? So, and in the similar manner, we can explain here this equation sets.
Okay. Thanks.
Okay.
And you also showed a very interesting paper on this subjective memory loss, sir, that decoding cognitive health. Yeah, something. I don't
Yes. Yeah.
completely remember.
This
So
one.
could you just wanted you to just dwell on it a little more? What kind of methodology you used, and
Oh,
uh, if you could,
essentially here,
could you
what we
please
have
go
done,
through those slides? Yeah.
yeah. So what we had done here, I hope that my slides are visible for this.
Yes, yes, yes.
So this, you can see this is the comprehensive evaluation. So our objective was that since a few works has been done, especially for SMC, so our concept was that for the researchers to give our insights that at what condition which algorithm could be suitable. So, I mean, as we have, I think I missed a few insight here. I mean, we have not given those experimental part here. So, but we have given essentially several shallow learning algorithm, deep learning algorithm, ensemble deep learning algorithm, randomized Bayes algorithm. This is a comprehensive evaluation. And we have shown that if you are, means if the data is imbalanced, then what to do? If the data is a smaller size, what to do? If the data is large, what to do? So, we have given several insights, and we have highlight and just connected with the Alzheimer, that this is the initial, or we can say the earliest stage of Alzheimer disease. So, but sorry, I missed to include those experimental part here, but we have given the framework. If you see here that we have considered this pre-processing, like we just consider SMRI scans from ADNI database, and we pre-process, like we have some toolboxes, and from this we just extract this gray matter, white matter, and JD different, and then we use several, we extract those features using these atlas, and we finally got, since the data was small, especially for SMC, what is available in the literature. So, if we have the smaller size data, then we are really face difficulty, especially if you really want to use deep learning based algorithm.
Sir,
So,
excuse me, sir. Actually,
please.
we were actually interested in working in some neuroimaging data, fMRI. So there, just wanted to you to please explain this feature extraction part also, which we can also consider, because I've seen many people utilize CNNs for feature extraction.
Hmm.
So how was this part done? If you could explain, or
Those, madam, for this part, we are using the standard feature extraction techniques. So our contribution essentially in most of the papers are not in that direction, that we are not developing feature extraction techniques here. So we are using feature extractions techniques, and then our approach is different. We are developing our algorithms, or especially for this case, whatever feature extraction techniques were there in the literature, we just use it, and using that data, we extract those features, and then we use different classifiers. As we mentioned, that we use hyperplane based classifier or randomized based classifier. So not for developing our own feature extraction techniques. It was not our contributions. Is that okay? Hello?
yes, all right, sir. Thanks. I had a couple other questions, but I would let others ask, and then maybe I'll come back again.
Yeah, maybe we can
Thank you.
discuss other time also.
Yeah.
Hmm.
Sir, thank you so much for such a valuable and engaging session. Your clarity of thought and in depth explanations have made the lecture both informative and inspiring. We truly gained a lot from it. Sir, I would also kindly request you to share the slides so we can review and reinforce our understanding.
Okay, I can share, no problem. So nothing is confidential here. I can share.
Okay, sir. Okay. Thank you so much. Thank you very much.
Thanks.
Uh, Our second speaker of the day has already joined the session. I am truly honored to introduce him, Dr. Subramanya Gorthi. Dr. Gorthi is an associate professor in the Department of Electrical Engineering at IIT Tirupati. He earned his PhD in medical imaging from EPFL, Switzerland, following postdoctoral research at EPFL and at Harvard Medical School and Boston Children's Hospital. Before joining as faculty, he served as chief engineer in the Health and Medical Equipment Division at Samsung R&D Institute, Bangalore. His research interests include medical imaging, image processing, computer vision, signal processing, and deep learning for healthcare applications. He has authored over 40 publications in leading international journals and conferences. Sir, we are truly grateful to have you with us today. I would now request you to kindly take over the session. Sir, you are not audible.
Yeah, sorry for that. Hope now I'm audible, as well as I hope the screen is visible.
Yes, sir, you're audible as well as your screen is visible.
Great. Yeah. So thank you for inviting me to this 4 week, I think, summer school and deep learning from IIIT DM Jabalpur. So before I begin, I would also like to yeah, know till what time I can continue. So within how much time?
Sir, we can actually you can take until 1:15 as well, because we were
Okay.
already behind the schedule. So
Okay.
you can
So
continue.
yeah, till what time perhaps just you can suggest me till which time we can go on with the presentation so that I can pace accordingly.
Sir, 1 hour, 1.5, 1 hour is we can
Okay.
take.
Okay, sure. Perfect. Okay. So, yeah, I see that this session is on AI in healthcare. So, welcome you all. And again, thanks for inviting me. And so, the session is on AI in healthcare. I'll be focusing on AI in medical imaging. Given the time constraints that we have, I will mainly focusing on sinograms. So, which you could for now, those of you who are not into this could consider it as CT. This is a this is from which the CT image comes. So this is what primarily would be focused in this work. So I was asked to discuss about some of the research works that we are doing in medical imaging. So what I did is to put together some of the works related to primarily to CT imaging, and that's what we will discuss now for this rest of the session. If I have to classify, I would say we will look into 4 topics. One of them is about sinogram-based detection and classification, followed by fusion of features from both sinogram and CT, followed by sinogram enhancement, use of sinogram enhancement module in the process of reconstruction, and one topic where we use data augmentation based on the domain knowledge. So this is the content for today's talk. So I guess some of you might be already aware of computed tomography imaging, so which is also referred as computed axial tomography, CAT image, or in general, the CT scan. So this is how a typical a kind of a picture of how it would look like, a cartoon-like picture of how it would look like. So there is, so this is referred to as the, I think I could, yeah, this is referred to as the gantry into which the patient is sent inside. And this will be a rotating gantry. On one side, there is the source. Anyone by any chance know what is the type of electromagnetic waves used for CT imaging? So X-ray images, X-rays are used here in the electromagnetic spectrum. That's used as the signal that's used here, are the X-ray beams that will be sent here. So, someone once, yeah, good that people would had typed in that. Yeah, as and when there is something, you can talk as well over this thing. Okay, so there is an X-ray source here from which the X-ray beams would be coming. And exactly the other side, you could see panel of detectors, an array of detectors. Now these rays will pass through the object, and after it got attenuated, what is left is the intensity of it is detected by the X-ray detector present at that particular location. After that, what would happen is this keeps rotating, as you could see here. So both of them rotate simultaneously with the same speed, so that and they are in fact attached to the same rim that is rotating. Okay, so you have, so for example, you could think of it as, consider this direction as the direction Z. That means at one given Z value, you have a 2D object through which these X-ray beams are passing through. So you have essentially a one-dimensional projection of a 2D object. If the projection is like a planar one, but it could vary. Suppose it could be like a cone beam kind of thing. Then what you get is called as cone beam CT. Typically, again, here you normally, the most commonly used in many of these scanners is called as fan beam CT. That means one source is there. From that source, the X-ray beam is coming like this in the same planar. Okay. And then this passes through an object here, and there is an object here. And on the other side of it, you have the detector, X-ray detector. So you will have these things falling here, and the resulting, the intensity left after attenuation is what you see there. So this is a planar. This is the most common one, referred to as fan beam. There is one source, like the wings of the fan. Okay, it's coming down. Okay, so this is the fan, and of course it could be other way around also. For all initial models and also for all mathematical models, a parallel beam is also used. For example, this is your object. Now the beam will be parallel like this, and here is the detector on which things are detected. These are all the X-ray beams coming. So this is called as parallel beam. And as I said, if it is coming in 3D, that is referred to as cone beam. So you could see here that in case of a CT imaging, what is acquired is, if you consider the planar beams like fan beam and parallel beam, which is the most common ones, is that, as I said, once you take a projection, it is rotated. So mathematically, if you want to say, you have multiple 1D projections of a 2D object. That is what it is there with us, right? And the goal here in case of CT imaging is to reconstruct the 2D imaging, 2D image, the original 2D image from these multiple one-dimensional projections. So this is what is done. So as I said, you could see there, that is how the projections are done. Finally, this is what is obtained. And that's what we refer to as CT scan, which many of you are aware. But what is acquired is referred to as sinogram, which you see here. So essentially, you could see here on the x-axis, you have a projection angle. I will make it in more detail in the next slide. But for a given projection angle, on the array of detectors that you have, at each place, what is the intensity of the X-ray beam? So your x-axis tells you the projection angle. The y-axis will give you at that x value, projection angle value, what are the intensities of the beams that have of the X-ray beam received at that particular location. So that's referred to as sinogram. Now, what is done is, first step would be to acquire the sinogram. Second step will be to perform CT reconstruction. There are very well-developed and now well-used state-of-the-art methods for this purpose of reconstruction. And that will give us from these, this is a classical reconstruction problem, which you would find out very similar reconstruction problem in MR as well, since I see some. So we have seen that MR as well. I think the previous session was there. The reconstruction has quite a lot of similarities to the kind of reconstruction methods used here. Same, you would find out similarities even if you are working on, let's say, ultrasound imaging and so on. Okay, so the point here is this reconstruction can take up to 30 minutes. And most of the detection methods that have been developed are so far developed on CT scan itself. That is what is done here. Okay. So anyways, before I go into the application in little more detail, wanted to give you few more insights into the sinogram, how it forms. For example, consider you have a synthetic image I am taking here just to give a feel of how the sinogram would look like. Okay, this is considered the original object, which is kind of scanned. Now, we have, let's say, 3 projection angles for us to consider. This is just to get a feel of how the sinogram would look like. Now, suppose if projection angle is 0 degrees, okay, this projection angle is 0, you consider this vertical one as the projection angle, because you see where the source is and angle made by it with the x-axis you would consider rays are perpendicular to it. So if you consider it this way, you could see here that the output values of intensities that you would get would look something like this. Okay, because this region, let's say, what you are seeing there is assume that it's an attenuation coefficient. So you can always get that once you know what is the acquired one, what is the source intensity which you generated, the intensity you know, and what is received once you know the attenuation coefficients, we could get it. So typically the higher attenuation coefficient ones are shown in just a minute, let me erase this one. I'm just trying to. Okay, so the higher attenuation coefficients are shown in white. So you could see here the attenuation coefficient here. So essentially it accumulates all attenuation coefficients of the objects or pixels that are coming on its way. So you could see here the attenuation coefficient is high if I am plotting it like a curve there. Of course, the same thing like what we do in images can be shown with intensity values as well, which we show shortly. Now, if you look at here, one more angle, 45 degrees if I am taking, it's easy for you to figure out that this is the region where the attenuation coefficient is more. That's what now those values are shown on the y-axis. Now, another angle of 90 degrees, you would see this would come here and that would look something like this. So if you, just like the way we represent images, if you do that, this would essentially would form a patch, like a strip like this thing. So why we are spending some time to get an insight into this sinogram is that you could see here that at least in a very simple case, if consider now this one as a tumor, which is having a different attenuation coefficient from the rest of that. In such cases here, you could see in sinogram some pattern. But the problem with sinogram-based interpretation is it's not so human interpretable. Nevertheless, from the previous discussions that we did during the previous slide, you can see that the very information that you see in CT is very much latently there in the sinogram itself, because the CT is reconstructed from the sinogram itself. There is no additional input that comes in for CT reconstruction method. since the deep learning methods are well known to extract the inherent latent features, so the problem posed, so this is the work done by our PhD, primarily by one of our PhD student, Sindhura, who happens to be also did her, I think, the MTech in Applied DDM Jabalpur. So that's a coincidence. Okay, this work primarily, the problem that has been posed for her work is this thing. Since the information that we see here in CT image is latently there in the sinogram itself, and given that the CT reconstruction can take up to 30 minutes, whereas the sinogram acquisition will hardly happen in a couple of seconds, can we detect any of these injuries right away from the sinogram? Okay, CT reconstruction, as I said, is a laborious, time-taking step. There are a lot of methods like Fourier slice theorem to begin with, and after that, quite a few methods are there. So why we want? So that means even before the CT image is something where we have the spatial resolution. That's how the image would look like. Even before that gets reconstructed, can we do detection of whether there is any injury in that particular slice taken? Okay, or what is the type of injury? Can we tell that much even before that? So what could be the application of that? For example, the application that we considered are intracranial hemorrhages. For example, whenever an accident happens, there could be a bleeding happening in the brain, and for such any head injuries, the common modality that is used is CT for various reasons. First reason, in CT, you would see the bone intensities very clearly with a very good contrast. And these injuries are typically to the bones that you are going to look at. Second, it is inexpensive and available in quite a lot of places than what it is like other modalities like MR. Okay, anyway, X-ray you won't use because in X-ray you don't get the exact location. You could only see whether it's just one projection that is there. Okay, so that doesn't give you the type of injury and finer details. So the one which 3D images, 3D modalities are popular ones where are CT and MR. But here the contrast is better. The availability of it in hospitals is better. And third and equally important one is, although this is compared to acquisition, it is taking more time. This is much, much faster than what it takes for one to go into an MR machine and get the scan done. It is much faster. So for these reasons, CT happens to be the recommended default standard used in hospitals. And you might have heard something called as a golden hour. So once the accident happens, if the bleeding is happening, the first 1 hour is the most important one. The sooner that is detected and the treatment is given to that, the better are the chances of the quality of life after that for the patient, and sometimes even the mortality can be avoided. And these accidents are so common, like they say 6 million deaths per year and so on and so forth happening because of this. So the question is, if we could in fact do the detection of these injuries from sinograms, there is something called as a medical triage. You could think of it as a queue, where once a patient is found to have an injury, that will be the first person to pay attention to than any other people, particularly in scenarios that we come across in India. The ratio of patients to the doctor and as well as the hospitals is very scary, very challenging situation is there. So that is where we started with the question that can we do detection and classification of injuries from sinograms, till now people were using the CT image, which is in fact a reconstructed one from the sinogram. Okay, hope the context is clear to you. Then I will briefly touch upon what could be the type of injuries, so that will give you an idea of what kind of methodologies we need to develop if we have to do this detection from the sinograms. So this is a pictorial representation of one of the slices in the brain, and there are primarily around 5 major types of injuries that one would come across. For example, in the dura mater, in this region, after this is called as dura mater, is found between the skull and this dura material, that's called as subdural hematoma, and inside that this is called as interparenchymal hemorrhages, and in the ventricles this happens, that is called as intraventricular hemorrhages, and there is subarachnoid hemorrhage, and there are few other types of these things are there. So this is how they look in CT. You could see there that these are things can we detect from their respective sinograms that are expected. So that is the problem posed. And can we also detect what type of injury it is? Okay. So for this, what we did is we first developed something, a module which is referred to as intensity transformed sinogram synthesizer, followed by a detection module. The first step is to first see, can we detect there is an injury or not? Okay. So to appreciate why we need a module like intensity transformed, so-called intensity transformed sinogram synthesizer, let's have a look at this, how a doctor, for example, whoever is inspecting the CT images would be identifying any injuries in the CT images. For example, once you look at a raw CT image, that means before applying any intensity transformation, what is reconstructed from your algorithms would look something like this, where we could hardly see any contrast within the brain region. Okay. Then what people will do is, for example, the one which you see there on the right top corner is something referred to as Huntsfield units, which gives you the attenuation coefficients normalized with respect to water. So it is something like mu minus mu water by, I think, mu water is what they do it. And that's how they normalize these values, so that the values would become independent of the scanner used kind of thing. So they can range from -1000 to even 3000 and so on. Okay. So that's the range. Water stands here 0 because the attenuation coefficient for water is subtracted from water and normalized with respect to that value. So each has a different intensity range. So depending on which structures you want to inspect, you would apply a transform. Like suppose here the area you are looking is in between these areas. Okay. So then what will be done is you will apply any intensity till here to 0 and here to here the maximum one, and then you keep it this way. This is called as intensity windowing. This is very common. For example, if one wants to inspect the brain, this is the kind of intensity, the values, these Huntsfield units which I was referring to are well known. So they apply that here. They see then in the brain region, well, subdural region, this is another windowing is there. You want to see the soft tissues within the brain, there is another intensity transformation that people apply. Now the question is, the corresponding sinogram is here. Can I do something similar? Because to what we were doing as windowing operation to view different regions well in the sinogram is the problem posed here. Okay. So again, as I said, sinogram is reconstructed by accumulating all these intensities along the ray. And for one angle that you see is how you are getting those things. So from this, how do I get, can I synthesize a sinogram which is equivalent to, in a way, obtaining in a CT when I am doing intensity transformation. So that's why this is referred to as intensity transformed sinogram synthesizer module. So this is what the first work happens to be, and on top of it, detection algorithms are applied. So this idea again is none of the scanners as on today provide us with the sinograms. There are recently a publicly available sinogram data, but not on the medical one. It's on a it's from a different context they have obtained it. But for the medical imaging, as of now, since there are not many works in this direction, people perhaps haven't thought about having sinogram also kind of given as an output on which some algorithms can be developed. So now, anyways, coming back here, from a raw sinogram, we want to get a sinogram, for example, which if I reconstruct from here the CT image, that would be equivalent of brain windowed CT image. Same thing we want to get for subdural windowing. Similar thing, if I reconstruct from here, if I do CT recon, I should get from there the windowed, whichever I am looking here for soft tissues, if it is soft tissue, I should be getting that. So this is the idea. And again, how can I get the ground truth then? Well, at the time of training, what we did was we reconstructed the CT from sinograms. From there, we have, once the sinogram is there, it is after all a projections. We have seen an animation earlier. So similarly, you get sinogram. Make a note that this going to CT and from there getting this is required only during the training part. Testing part, anyway, the weights of the model are learned and from there you get it. So a simple unit model is used here for brain windowing, subdural windowing, soft tissue windowing. And now the purpose is not to come up with a state-of-the-art deep learning model. So we have taken the widely used unit model. Those of you who are in the medical imaging might be knowing this is a very popular model used in image segmentation in medical imaging, where there is this part is I'm sure by this time you would have been clear with encoder decoder architectures, right? This is an encoder, this is a decoder architectures, where encoder you downsample them every time, and number of feature maps that you extract, you keep doubling it. And while you are doing an uploading, what you do is the image from the encoder part, which has the same resolution, those features extracted are also concatenated from the in the encoder part, decoder part learned features also. And in this process, finally, you transform, you get input is an image and output will also be an image. Yeah. So this is what it is. And now to see, since we know the ground truth there, we look at to assess how good it is, mean square error. And there is another interesting important metric which I guess you might have come across in some other talks is mean structural similarity index metric is also there. So then we were comparing how good, and we could go up to 90 to 96% of same structural similarity is coming when we are doing this intensity transformed we are synthesizing these sinograms. Okay, these sinograms are now synthesized. So this slide, by the way, this work got published in 2024 in Medical Physics Journal. Okay, so you could go through my website and there is the link for this work is there. So this is a kind of almost the first work, or in fact the first work for synthesizer, and to deal with this in this manner, first work to do detection and classification from sinograms. Right now, those three channels are obtained now, and after that, the next goal would be to detect whether there is if there is any hemorrhage or not. Again, at that time, the kind of models we have used are ResNext, Inception, Vision Transformer. These are the existing models we have taken. And another model where we have taken on top of this Inception, we have used these RNNs as well. So for particularly bidirectional LSTMs and bidirectional gated recurrent units are the ones we were taking here, where to detect the injury in a given sinogram for a particular Z value, we consider the features extracted from the previous slice and the following slice as well. So that's what the proposed one. And the accuracies that we are getting to detect whether there is a hemorrhage or no hemorrhage, insufficient block. I think by this time, I guess you might have had some classes on CNN architectures, and Inception is very well-known one, which is like inception, dream in a dream like kind of thing. That's what the inception means. So they have, for example, do 1x1 convolutions. On the results of that, they do 3x3 fact features from multiple levels. Okay. So hopefully you had you have studied some RNNs also, and again gated recurrent units and LSTMs are pretty common ones. Okay, so which actually look into the neighborhood information. So these two are combined, and this gave very good results in terms of accuracies. There is a good jump. The results which you see in brackets is doing a detection at a patient level. This first one which you see, these are the numbers that are telling you the slice-wise accuracy. So we are able to do very good detection. And then an ablation study to see whether this synthesis of channels is really helping or not. And we see that synthesizing is indeed having a sinogram synthesizer for all the 3 channels is indeed helping to get very good results with some with improved accuracies. Okay. And then the next thing also these days, if you are working in any of the areas of deep learning, it's important to look at some level of interpretability as well. So what we are trying to look at here is, are these detections done by looking into the right areas? To study that, what we did is, this is the original CT image, this is the raw sinogram, and this we have the segmentations of our object of interest. So for that, we generated a sinogram, and this we are superposing over the original raw sinogram. This is how it looked like. And I'm sure maybe class activation maps, gradient class activation maps, that is the penultimate layer of your detection deep learning model, you would take them and see which regions spatially have contributed predominantly to arrive at a given decision can be observed from these GradCam maps. And we were happy to note that this is in fact done because these are not very human interpretable as we were thinking, but that information being latently there, deep learning methods are supposed to pick that up. And similar thing we have done for different natures of different types of injuries, and we see that this actually this is the one corresponding to, let's say, the injury region. So we see that it's in fact arriving at the decision by predominantly affected looking into those regions as well. So that's a very, I think, is a very interesting and good work by the student. And then we also had seen, can we also kind of get a classification? How accurately can we do the classification of these injuries? So that area, so multi-label classification here, multi-label classification here, a patient can have different types of injuries also. So even in a single slice, while there are 5 classes, it can have, let's say, 1-2 types of injuries can be there. Okay. So then epidural hematoma, interparenchymal hematoma, all these 5 are considered. For example, you can have a look at area under the curve. So again, it does a very decent job in accurately classifying them. And but of course, for epidural hematoma, it was not doing a great job. It's around 55% accuracy it is doing in terms of AUC. Of course, this is slightly misleading here. You can have a area under the curve should give you a better result because of some class imbalance. And later, some other student has worked on having a label imbalance aware loss function. So that has improved these numbers further significantly. Anyway, in the interest of time, we will not go through that right now. Okay. So not only that, now in practice, what would happen is while rotating this gantry, because of these mechanical constraints, there could be some error that got introduced. For example, this rotation might be having an error of 0.1 degrees. For example, this could be usually taken for every 1 degree, one projection is taken. While making this rotation, instead of from 1 degree to 2 degree, it might be 2.1 degree. So the study that has been conducted here is, this error is in fact in the sinogram domain. That's what, because that is what actually got acquired. And when there is an offset error of 1 degree, 0.1 degree, let's say, how much are the results in if we are performing this detection in sinogram versus this detection and classifications in the CT domain are getting affected. So what is observed here with an offset error is that while without any offset error, the trained model on the CT images gave 94%. And here also 94%. Some differences there in decimals. Other than that, they are on par. And here the drop is by 2% when there is even a slight change in the offset value. And here it is very negligible comparatively. It's just 0.15%. So this is a good news. And it is intuitively, this makes sense because always the error gets introduced in the sinogram. And another important experiment that has been done for these kinds of models is the kind of noise that you find is unique in each of these modalities. That's what one should pay attention. Those of you who are working in a specific modality, here it is a Poisson noise in case of CT images. This is the predominant noise, while also the other noises could exist. Now, this comes from Poisson, comes from how the electrons gets emitted in the X-ray beams, and then in the detector, the hitting of that to the detector, so on and so forth. Okay, when then this energy hits there and electron coming out and so on and so forth based on the physics part. So here also this has brought, if a Poisson noise is introduced here, then a typical Poisson noise that one could find out. Again, here the drop was close to 3% in case of CT image. The result accuracies have come down. On the other hand, in sinogram, this is very negligible, only 0.1%. This is also a very important result here. Okay, so that's the key medical physics 2024 paper that has worked on. The other continuation of work that the student has done is not in all cases people. So that work, the target is that when we come across the injuries where we want to create a medical triage, in which case even without reconstruction of CT, we want to do it. This is not all the times the need. There could be applications where the construction of CT is not a problem. So in such cases, does extracting features from sinogram and the CT and then fusing the features from both, will that help? So this is the next continuation of the work done. So particularly we consider the scenarios where we have a limited data, because again in medical images, unlike in some of the computer vision applications, have very limited annotated data, because getting annotations is very expensive. So the question is, when I have limited data, if I have a too big network, the augmentation can support it only to some extent. So in such cases, when I need to use a lightweight model with limited data, will the fusion would help? Because anyways, if I'm using a very huge network and if I have thousands of CT scans, that's a different scenario. There, because the information that is inherently there in both is same. So that cases, it could give you similar result. But under limited annotated data constraint, and also in scenarios where we want the model to be lightweight so that can be deployed in the regular clinical environment itself. If anyway I have the sinogram is what is acquired, that is there. CT anyway has to be reconstructed, because that is where the spatial information is coming out, and that's what doctors look into. Combining the features from both will add value or not. So we found that it does indeed add value. For example, when there is these are few injuries that we are showing some illustrations here. For example, for an injury, particularly when the injury is very small, where it is getting missed by both CT and sinogram, where the doctors, by the algorithms, but the doctor could see and find out this is an injury. Mixing them both, combining them both is giving the very good results. So this is one study where, as I said, lightweight model is also a scenario here. So that time we considered efficient net and mobile net V2, and 1,000 subjects with 42,000 slices are used for training, and 8,000 for validation, and 10,000 for the testing. So the accuracies you could see here, 8174 with CT alone and sinogram respectively. Combining them gave 84%. So in this application, efficient net performed better than the mobile net V2. So this is another application where you need not, the message here is, need not, if time is not a constraint for you, you can in fact still consider sinograms as a very useful information where one could consider combining merging features extracted from both these modalities. So this is another work done by Mr. Sidhar. He was an MS student who recently finished his MS, and this he has done as a part of ICASP challenge in April 2024. It is a speech, acoustics, and signal processing international conference in that area, where the problem they have given is they have low dose CT. That means the intensity with which they send these X-ray beams are of low dose. And again, this is now a cone beam. So earlier I said it's a planar fan beam and parallel beam are the experiments done earlier. This is a fan beam model. So in that case, how do you need to give an sinogram? Now the goal is not detection and classification. Those tasks are done. This is the task of reconstructing the CT image, the inverse problem essentially. So what we have introduced based on the experience that we have seen earlier, that the sinogram gives you a very key information. So a sinogram, and what we call it as sinogram enhancement module, is what we introduced here. Followed by that, the conventional CT image reconstruction methods are used, and followed by that again one enhancement module in the spatial domain. So this is the pipeline proposed, and sinogram enhancement, other things are done, and it in fact has given pretty good results in terms of mean square errors is what the challenge organizers were looking at it. And overall, this challenge, it stood, I think, in the third place, this algorithm. So gave very good results, both in the low dose and clinical dose. Clinical dose is currently what is practiced. Low dose is an emerging research area where they are trying to reduce the dose, but still want to get good, accurate images. Okay, so this is the third work. And since we have touched upon the traumatic brain injury one, I thought I will also mention about a bit of domain knowledge that one could use. For example, the conventional approaches you give this is a recent work that got published by Sindhura herself in pattern recognition letters in Feb 2025 this year, where for this, for example, in the brain, when you see the images in the human body, there is an inherent approximate bilateral symmetry is what you observe with respect to this axis, which is called as mid-sagittal plane. So can we, this is the domain knowledge, or you can call it as the clinical knowledge. So the question posed is, can we leverage this to identify if there are any injuries or detection of injuries? Not only detection, but also segmentation of those injuries. Okay, so there are very few cases where the symmetric injury is there, but even in those cases, we found that this is still helpful. So typical models, CT images are given as an input, and hemorrhage has been detected. So what is done here is something we refer to as asymmetry map, where all the CT images are aligned with respect to this mid-sagittal plane. This is one slice here. And after alignment, what we do is this image is flipped horizontally, and you take the difference of it. And after that, you do a bit of processing like connected components, the difference between them, applying a threshold, beyond a threshold, keeping that to generate this asymmetry map. So here, higher the value, that means typically once you make it vertically aligned, 90 degrees here, this line, mid-sagittal plane, we expect asymmetry means the corresponding pixels should have more or less similar intensities. But you could see where, as and when there is an injury, that region will have a different thing. So this is how the asymmetry maps have been generated. And of course, once this is generated, this can be fed in various ways as an input along with the original CT image, and this can be used, for example, to improve the segmentation accuracies. So how is this done? So this again has been tried on different kinds of architectures for segmentation, starting from UNet, multi-resolution UNet, UNet 3++ U2Net. These are some of the very popular, widely used methods. And then this has been given as an additional input, combined cleverly there, and formed to give very good improve the results consistently and significantly with, we call this as a synthesizer again, because the second image is synthesized based on the first image and this symmetry around the mid-sagittal plane. So you can see here, for example, 56 to 66% DSC. DSC, by the way, gives a measure of overlap, which is 2 times the intersection area between the ground truth and the automated segmentation, whole divide normalized with respect to the volume of the ground truth segmentation and the volume of plus the volume of the automated segmentation. So yeah, in all these methods, it has found to consistently give better results for segmentation. And the detection also, we did the same thing for detection also. Both in detection also, detection means there is no decoder, just the encoder part that we have seen. So it improved both detection and classification. So this is, since this is somewhat closer to one of these things that we, application wise, it is same as this. So just wanted to mention this also. Yeah. So maybe I will stop here so that we can take up questions and then discuss further based on your the questions that you have. Okay. So yeah, hopefully we have at least 10 minutes for questions and all. You can, yeah, you can ask. Is it radon transform? One of you were asking it. That's exactly how you generate sinogram. That's essentially the radon transform. So since right now the sinograms are not publicly available, they are there with the machine. We apply the radon transform to get the sinograms, do it, and inverse radon transform. The other one we can't get. That's right. So some of you had has written this question: is it radon transform is sinogram? Yes, but this radon transform, once you apply it, you get one column of this thing, and then once you keep changing this projection angles, each column of that sinogram is what you get there. Radon transform gives you the sinogram when this transform is applied for each projection. Hope that answers your question. Right, good. Any other questions? It could be generic. I'll give it a try. If I know, I'll tell. Anything in healthcare or medical imaging in general also, you can, if you have any questions, you can pose. So could you please explain inception blocks used in detection module? What are they and why they are needed? Okay. So, well, see, as I said, what we were trying here to test is not to find out the best, yeah, not to find out the best architecture. The goal is just to find out how close we could go in terms of detection with any of these deep learning models. Having said that, inception works quite well. So I'll just go back to the presentation for that particular one, and maybe that's easier to illustrate there. Yeah. So here what were used is she was using a 3 blocks of this inception. Inception is essentially I thought inception net and all you might have studied in CNNs. So essentially what it does is, for example, when you want to look at features at different scales, one way you do it is, for example, if you fix the window size to 3x3, okay, then you do you find out the parameter, and so we call this as feature map. Let's say some 120 feature maps are computed. Then what is done is you want to look at the features at different scales. So then what you could do, you could do a pooling, or using pooling you can do downsampling, and then again use some. Now your image is at a lower dimensional space, so you could use, if you want, you can even use more number of. That's what typically done. You will use even more feature maps to be learned. Okay, say earlier, let's say you are using 100. Now you anyway downsample, you use 200 feature maps of size, let's say 3x3. But make a note here, since you downsample, let's say by a factor of 2, you are in fact looking at a range of 6x6 in the image, right? So this is what used to be done. Typically, this inception, I think, is also called as Google, if I remember correctly. So what they have come up with is use downsampling using the same layer. This is computationally expensive. Reason being, this feature, this is not just 6x6. 3x3, 3x3 x 100 is what you have to apply, and you keep on doing it. Rather, the better optimized way to look at it different scales is you apply 1x1 filter. On top of that result, you apply, let's say, 3x3 and so on and so forth. So again, you will find out very good video lectures and other things on inception over the internet. Give it a try, and this is one of the very well working models. Anyway, we considered other models also. For example, ResNext. It is just to see how is the trend here. So that also gave good results. Then the reviewers asked for recent methods because those were proposed already around 10 years. So at that time, we took the vision transformer model also, which also gave results which are very similar to inception. But again, among these three, inception gave better results. So we built on top of it, introduced RNN also. So that's what has been done here. Okay. So there is, hope that answers the question. Okay, good. Any other questions? We have, if you want, we have around 5 more minutes more, roughly. So any possibility to extend this idea to non-medical images? For example, pathological speech analysis. First convolve 1D speech to 2D sinogram and perform the analysis. The question is not very clear to me. For example, if it is about, what is acquired is sinogram. So that's what we are using here. So sinogram is very specific to CT imaging modality. So that way, doing detection and classification, fun sinogram could not be applied to the audio signal. But if your question is different, where you are asking about, can I use this inception thing, which the one of the earlier participant was asking, inception idea can be applied, and I'm sure by this time people would have obtained to the speech as well. But if you are talking about the sinogram idea, you could think of it this way. If there is, for whichever application you are considering, if that has something acquired is different from what you finally utilize, in such cases, you could think of a similar. Hope that answers your question. Otherwise, you can write again in chat. And there is another question nowadays, research going on in transformer, explainable AI and GANs. That's true. Yeah. So I wish I could spend some time on the directions of in which directions the current AI research is going on. But since you have asked, I will quickly share some thoughts about that. Explainable AI is a very, very important area, particularly in medical imaging, and a lot of research is going on in that direction these days. For example, consider a case of COVID, just to illustrate you why explainable AI is so important. If the algorithm deep learning model that you have given is just telling you that he's affected by COVID, for that to take right away by the doctor, definitely he wants to know why the deep learning model thought that this patient see from the CT's image of the patient that he or she has COVID. So that's the thought process to convince him. So we have seen a simple way to do that is we have seen a grad cam representation in this presentation. So if, for example, in addition to that, if the algorithm also highlights some area in that image and tells that I see an abnormality in this region, which is not found in patient in the normal subjects, who is not a patient is referred to as subject in medical imaging, or in normal person who is not affected by that particular disorder. I don't see any, I see an abnormality in this region, which led me to this. So this is very, very important area. Not only that, there is another way of explainability these days people are using where it is something related to image retrieval, where the algorithm, in addition to giving its detection as positive or negative, also pulls up from the available annotated data given by the experts that I see that this image is very similar in so and so regions in with so and so training data sets. And since you have given for those training data sets and assign them to an abnormality, let's say class B, I also came to the conclusion that this is class B. So this is explainability. Okay, this is very, very important. And another topic that one of you has mentioned is GANs. The same Rajesh Kumar was mentioning is generative adversarial networks. This is again a very important area, but again, this is an area where you have to tread the path with a lot of caution, because the reason being there is a physics involved in getting those images. And are these models, the images that you generated, are respecting that and giving you anything meaningful? So we had mixed experiences with generative adversarial networks. In some cases, when the data is too scarce to get, too few to get, we found that good. But for example, in synthesis of sinogram synthesis, if you had noticed, there is still a 10% gap in terms of structural similarity index. So when we tried GANs, we could not improve it further. We tried with transformers as well. There was not much improvement. And you see lots and lots of work these days where people are using to move from one generating from one image. Let's say I acquire CT, can I generate MR? So people have to be, although you find a lot of literature there, you also find, if you dive pitfalls also in that. So because if the very CT image cannot see into what the other thing could look, the MR could see, if you are generating one from the other, that's a dangerous thing to do. Okay, so hope I at least gave some idea about that. Okay, so yeah, let me go through, since there are few other comments. Can you suggest, yeah, again, I think transformers, we discussed a few. In the interest of time, I'll move to other comment. Can I correlate this for and start working in future? Can you suggest? Yes. So maybe hopefully this discussion gave you some ideas. What is the minimum sample image we need to start working on medical images? That depends on how much variability you could expect in that particular one. What are the other classes you have? How close and how different are? These all will dictate how much data set you need. But typically in the medical imaging, you have it in order of thousands, not like in computer vision where you have a good data set means 1 lakh, 1 million images is what we're talking about here. It's hardly few thousands for most of the applications, barring few. So yeah, those are the points from my, I hope I kind of touched upon all the comments mentioned here. Feel free to unmute your mic and also ask if you have any queries. Yeah, my email ID is s.gorthi. I can type here if you have any queries. iittp.ac.in. So this is the email ID. If you have any queries, you can post there as well. So any other questions? Yeah, if not, back to.
Yes, sir. Thank you so much for such a knowledgeable and detailed session, sir. We really appreciate your time, even when we were a little behind schedule. Sir, I would also request you to kindly share the slides so
Yeah,
we
sure.
can
I'll do
refer
that.
to them.
We'll definitely do that. We'll write it down.
Okay. Thank you so
Yeah.
much, sir.
Thank you all. Thank you for your questions that made it more engaging. And I hope you got few additional insights. Hope this helped. Thanks a lot. Bye. Take care.
Thank you, sir. Goodbye, sir.
Yeah, I'm leaving.